right, a very good afternoon, everybody, and a warm welcome to this session on gastroenterology. All right, and thanks for joining us. We have Bareng, Case, Onchiretse, Yesu, Ndi Mugo. Welcome. Uh, yeah, so we are going to get started. Let's go. So this, as you know, guys, is a summary of high yield pointers with the FCP2 exam. It is nice for consolidation. So we're not going to be, lecturing as such. It's just a summation of information that I'm sure you guys already know. And I'm not a gastroenterologist. I'm just a regular physician trying to help uh, our colleagues who are going in for exams. Excuse me. So God bless, and let's get started, right? Okay, so because there's a lot of content to get through, I am not going to ask for input on every question. It's just on questions here and there that I'll be asking for input. But otherwise, we're just going to go through the stem of the question and the answers, okay? I've got a mix of OSCE type questions and common exam scripts. Okay, so describe the following. What disease is associated with the picture? Which organs are predominantly involved? How is definitive diagnosis established? How do you treat the disorder? So, this is Case of Fleischer rings in Descemet's membrane. So, this is Wilson's disease. So, Wilson's is often regarded as so-called copper overload. It affects predominantly the liver and the brain, causes hepatolenticular degeneration, can cause hemolysis as well. The way you diagnose this is with urine copper measurement. In the 24-hour, urine copper is going to be high. You may have Case of Fleischer rings on slit lamp examination. Serum ceruloplasmin can guide you, but it's not diagnostic. So usually your serum ceruloplasmin is going to be low. And the gold standard test is going to be liver biopsy with quantitative copper assays. And you're basically going to chelate. So the treatment here is you chelate the copper with zinc. It's something called trientine. Just like how with hemochromatosis, we use desferrioxamine. With copper, we use trientine. Right? Okay, 43-year-old male with a history of duodenal ulcer presents with a 3-day history of anorexia and vomiting. Okay, if you look closely at the gas, and by the way, this evening on the CCP, we're covering a session on a blood gas analysis, so feel free to join us there. It's a free initiative. I've got a couple of case studies, and we're going to look at also some more complicated mixed acid-base disturbances. It's a nice one to attend. Yeah, so your sodium is 138, potassium 2.4, which is low. Chloride is low at 88. Bicarb is high at 40. This is very high, right? So that probably implies some acid loss. Okay. A pH 7.52 is metabolic alkalosis with a PCO2 of 50 in attempt to compensate. Urine sodium is 38 and urine potassium 60. So what is the acid-base disorder? So guys, look carefully, right? It's low potassium, low chloride with metabolic alkalosis. So it is hypokalemic, hypochloremic metabolic alkalosis. And this can only be due to, copious vomiting, as one would expect with gastric outlet obstruction. And that is that. What sign do you expect? It's called a succussion splash, right, of gastric outlet obstruction. Okay. Okay, let's do some exam scripts now. Got a middle-aged male with a history of heavy tobacco and alcohol use. He presents with rapidly progressive weight loss, dysphagia, initially for solids, now for liquids. So that's very important to note. Retrosternal chest pain, and he has diminished hemoglobin. What's the diagnosis? What is it due to? Okay, let's open up the floor and ask you guys to type in the chat box. What's the diagnosis here? Middle-aged male, he's a heavy smoker and alcohol user with rapidly progressive weight loss and dysphagia, which is progressive. First for solids, now for liquids. Retrosternal chest pain together with anemia. Let's take your submissions on this one, everybody. Feel free to type in the chat box. Then we can take it forward. Hmm? Any ideas? Anybody? Somebody? Alrighty. Okay, let's have a look. Auntie Letsa says possible CA esophagus. Yesu says esophageal CA. All right, that's a reasonable choice and is absolutely true. Dysphagia on account of malignancy. So note the risk factors here, obviously tobacco and alcohol use, right? And of course, to differentiate functional from structural issues, the dysphagia, which is initially worse for solids and then for liquids, tells you it's more likely a structural problem versus dysphagia that is equally bad for solids and liquids, which implies a dysmotility problem. Okay. Male patient, middle-aged, with a history of inhalant allergies, wheezing, chronic rhinitis, who got this hypersensitivity background, presents with several years of dysphagia and a history of food impaction, retrosternal burning, and occasional regurgitation of acidic content. He has a normal white cell count, but on the differential, he has eosinophils. Now, let's think about this, right? Hypersensitivity, eosinophilia is a very specific phenotype we're aiming at here. And he has raised immunoglobulin E. Aha. And this is a giveaway, guys. The scope that you do shows multiple mucosal rings. Does anybody know what condition this is? Putting everything together, the atopy, the eosinophilia, the high IgE, the history of dysphagia, food impaction, and also, very especially, the scope finding of multiple mucosal rings. All right. This is what we call eosinophilic esophagitis. Okay, so the clues there is a hypersensitivity, together with the high IgE, the eosinophilia on the differential, and the multiple mucosal rings. Very specific phenotype. Healthy patient here comes in with intermittent retrosternal burning, regurgitation of acidic material, sensation of chronic lump in the throat, and repetitive throat clearing. Okay, so this is the typical picture of gastroesophageal reflux disease. Quite common nowadays. Good. Watch out because GERD can actually predispose to Barrett's metaplasia because of chronic reflux. And then, of course, you guys know there's metaplasia of the lower third of the esophageal epithelium, which is normally stratified squamous. And then you have metaplasia to become columnar. And that, of course, is a pre-malignant lesion, which is always why we're very concerned about that. Okay, this is back to the OSCE type question. 35-year-old female with a loss of weight, dyspnea, dry eyes. Now, this is classically not a GI case, but interesting nonetheless. So what we're seeing here is uveitis, anterior uveitis. Here we're seeing bihilar adenopathy. Here there's, parachitomegaly. This is disophalangeal cyst, and this is erythema nodosum. Anybody tell me what this patient has? I know it is not necessarily a GI or a hepatology kind of question, but what's the unifying diagnosis, guys? Anterior uveitis, maybe some retinitis, bihilar adenopathy, pseudomegaly, distal bony cyst, erythema nodosum. Anybody? Somebody? Okay, sarcoidosis, right? This is sarcoidosis. And there's lots of renal. I think we covered this question in the last presentation on nephrology, so we're not going to get into this. Okay, so this is more of a hematology question, but because of malabsorption syndromes, you can also lump it together with GI. So this is the typical microcytic hypochromic anemia. As you can see, very pale discs with an increased area of central pallor. Okay, and if you look very closely, you have some rouleau formation here, where there's sticky red cells which are forming like a stack here as well. And you also have the red cells being of varying sizes and shapes. So we call that anisocytosis and poikilocytosis. Okay, and 5 possible causes for this picture. You guys know microcytic anemia can be due to TAILS. The acronym is TAILS. So T for thalassemia, A for anemia of chronic diseases, I for iron deficiency, L for lead poisoning, S for sideroblastosis. Okay, so that's it. Okay, back to our exam scripts. Caucasian patient older than 50 years comes in with long-standing history of retrosternal burning, sensation of chronic lump in the throat, repetitive throat clearing, and this is basically what we said in the previous question about GERD. So you can assume she has GERD, but in addition to the GERD, she also on scope has velvety red columnar epithelium in the distal esophagus. And that's what we said. Chronic GERD is a precursor to Barrett's metaplasia. And that's exactly how Barrett's will manifest, on the scope. You're going to see the salmon-colored kind of pinkish area. And the biopsy of the columnar epithelium shows you intestinal metaplasia. And that's what we're talking about, right? That is definitely going to be Barrett's esophagus. Absolutely. Otherwise, a healthy patient older than about 45 years presents with several weeks of epigastric, so-called hunger type pain that wakes up from sleep. So anything that wakes the patient from sleep has got to be organic disease, right? You can't say it's psychological kind of thing because it's waking the patient from sleep. And it occurs 3 hours after meals and is relieved with antacids or eating. You got epigastric tenderness, you got no weight loss, no vomiting. Barium swallow shows a well demarcated crater in the duodenal bulb. So the question goes on to ask, what's the diagnosis and what's the likely cause? Well, you guys know this is duodenal ulcer, right? Caused by Helicobacter pylori. So usually ulcers, ulcer pain, which is relieved by eating, relieved by antacids, is most likely duodenal, right? And because there's no pain on eating, these patients don't have weight loss. Versus gastric ulcers, where the pain is worse on eating. So what they do is they tend not to eat, and because they don't eat, they lose weight. And so that can be, on history, one of the diagnostic, but kind of suggestive clues as to whether you're dealing with a duodenal ulcer versus a gastric ulcer. Okay. Patient here presents with several year history of progressive difficulty swallowing solids, difficulty swallowing liquids, difficulty initiating a burp, and the medical word for burp is called eructation. Okay, weight loss, and this is not a South African text, so they use pounds. So weight loss of 5 to 10 pounds, which what 2 to 3 kgs maybe. Intermittent chest pain and barium swallow shows you beak-like narrowing. So this is probably the highest yield statement in this whole scenario. If you have beak-like narrowing, okay, where the dysphagia that is kind of equally bad for solids and liquids, it's a dysmotility problem, okay? And the poster child for dysmotility is achalasia. Achalasia, where there's a degeneration of the mentric plexus and there's a increased pressure in the lower esophageal sphincter, a failure to relax, essentially, and then you get this achalasia. All right, this is Clostridium-like organism test, the CLO test, and it is a measure for Helicobacter pylori, essentially, and you do it at the time of scope. But nowadays, guys, you got H. pylori stool antigen testing as well. So, yeah, CLO test you can do at the time of scope or not. It basically shows Helicobacter, and Helicobacter, as you guys know, is one of the main reasons why people get peptic ulcer disease. Okay. The whole thing here is that H. pylori produces urease, and urease cleaves urea to liberate ammonia and carbon dioxide, and that mediates alkaline pH, and that catalyzes the pink color on the agar. So that is the reason why you have a positive test. And the way you treat peptic ulcer, I'm sure you guys know, is triple therapy. So using a PPI together with a macrolide and a beta-lactam. So you can go clarithromycin and amoxicillin 7 to 14 days together with a PPI. It's associated with Crohn's is called ASCA, which is anti-Saccharomyces cerevisiae antibody. Okay, and thanks, case, Crohn's disease. And when are you going to undergo surgery? Couple of indications: toxic megacolon, intractable or fulminating disease, massive GI bleed as part of colon cancer prophylaxis if there's obstructive bowel, if there's intractable fistula not responding to medical treatment, and strictures, right? So a lot of reasons. And those are all really complications of Crohn's, right? Crohn's tends to cause perianal abscesses and fistulas and fissures and things like that. Ulcerative colitis doesn't really cause that because remember, ulcerative colitis is more mucosal, whereas Crohn's is more transmural. Okay, and Crohn's has skip lesions and can affect any area of the bowel from the mouth to the anus. But ulcerative colitis, like the name implies, colitis is restricted to the colon. It involves the rectum by definition. It can cause some backwash ileitis, but ulcerative colitis typically complicates with toxic megacolon, whereas Crohn's can do toxic megacolon, but not often. It more likely causes visualization and fissuring and bowel obstruction and perforation and that kind of thing. All right. Middle-aged patient with a long history of intermittent retrosternal burning and occasional regurgitation of acid material develops gradual or progressive difficulty swallowing solids and then liquids. Okay, so this is most likely going to be peptic stricture. Okay, peptic benign esophageal stricture. A young patient presents with recurrent episodes of acute chest pain, and look at this side after ingesting cold liquids. That is a bit strange. Recurrent episodes of difficulty swallowing. Sometimes, you get worried about cardiac ischemia, but he had a negative stress test. And this is the tip off here, guys. This is the highest yield statement in this scenario. The barium swallow shows you a corkscrew pattern. So this is going to be something we call diffuse esophageal spasm. Diffuse esophageal spasm. So we already covered eosinophilic esophagitis. We've covered peptic ulcer. We've covered GERD. We've covered Barrett's metaplasia. Okay. We've covered achalasia. And now we're looking at diffuse esophageal spasm. All of these you can see involve the esophagus to a greater or lesser degree, but they are very specific exam scripts. So that is the purpose of this talk, guys, to make you aware of the certain buzz phrases and catchwords, etc., that they use to allude to a specific diagnosis. Okay. Here, the patient presents with years of intermittent difficulty. Years, that's very important. Intermittent difficulty swallowing solids, especially chicken or bread, often relieved, and this is important, with regurgitation or changing position. So there's no weight loss and there's no anemia. This is most likely a Schatzky ring. So dysphagia due to a Schatzky ring. All right, this patient has ulcerative colitis. You know that this hugely dilated colon. So this is toxic megacolon, which has complicated ulcerative colitis. Okay, so you got very large bowel. So this is what we call HOSTRA. So remember, guys, on the abdominal X-ray, the difference between large and small bowel. So large bowel tends to be more centrally located and has HOSTRA, which pervade the entire, diameter of the lumen of the bowel, versus valvular canaventes. Valvular canaventes is small bowel, and that doesn't. I beg your pardon. Valvular canaventes goes to the entire lumen, but HOSTRA doesn't. Okay. Anyway, what's the diagnosis? This is toxic megacolon. And outline your management, mid to high care, bilateral IV lines, volume resuscitation, inform the surgeons, cross-match the patient, do your basic bloods, transfuse if HP is below 10 to optimize for theater, because these patients can easily rupture and you have perforated bowel and peritonitis, right? So keep the patient nil per os, if in nasogastric tube, IV antibiotics. Avoid 5-acetyl-salicylic acid, which you would consider in a flare of UC, but this is not a flare. This is toxic megacolon. So don't give that because that causes paradoxical worsening. Start IV corticosteroids and IV analgesia. But the most important thing, optimize the patient for theater, phone the surgeon. This is a surgical emergency. Okay. 50-year-old male presents with recurrent faints and abdominal surgical scar. Now, why are they telling us abdominal surgical scar? Let's have a look. He's got a microcytic anemia. Okay, if you give him a 75-gram oral glucose load, what happens is that the sugar rises as expected, but when you hit 90 minutes, the sugar drops to 2.1 and then to 3. Now, if you put everything together, this recurrent faints probably due to hypoglycemia, abdominal surgical scar probably due to gastrectomy. So this is what we call dumping syndrome, okay? Dumping syndrome due to malabsorption and this gastrectomy, and there's this dumping of acidic chyme or food from the stomach straight into the bowel without it being properly digested. And as a result, you have a lag in your hypoglycemia. You have hypoglycemia, which lags after the food or the glucose load. Okay, dumping syndrome. Okay, how about this one? Teen patient on oral doxy for chronic treatment of acne presents with an acute onset of pain with swallowing and retrosternal pain. Okay, so this is known as pill-induced esophagitis. Guys, you must remember the link between doxycycline and esophagitis. This is what we call pill-induced esophagitis, okay? So eosinophilic esophagitis is slightly different, Sunira. We already covered the script for that. A patient who has a background of atopy and rhinitis and asthma, and who has a high IgE and eosinophilia on the diff, now comes in with a typical picture of esophagitis. So this is pill-induced esophagitis. Okay, here we have an elderly patient with a history of stable ischemic heart disease on daily aspirin. He is prescribed a Medrol dose pack for acute poison IV and naproxen sodium for osteoarthritis pain. Okay, so it's basically steroids and non-steroidals. Okay, had a recent normal colo. She then develops dark tarry stools, occasional lightheadedness, epigastric tenderness. Guys, does anybody want to tell me what has happened to this lady? She had poison IV. Somebody gave her a steroid and somebody gave her non-steroidal, and now she has dark tarry stools with occasional lightheadedness, epigastric tenderness. Guys, what is the diagnosis? What's going on in this lady? Any ideas? Type in the chat box for me. Anybody? Somebody? Anybody out there? Hmm. Oh, all right. You guys know this is bleeding ulceration in the stomach and duodenum. This is most like upper GI bleed on account of a bleeding ulcer. Remember, non-steroidals, guys, together with steroids, they can both cause ulcers. Okay. Okay, let's have a look. Let's have a look. Let's have a look. Upper GI bleed. Thank you. Male patient, 30 to 50 years old, round about there, presents with recurrent duodenal ulcers, with diarrhea, rectal burning, weight loss. This is important, guys. Serum gastrin above 1,000. Okay, so this obviously speaks to Zollinger-Ellison syndrome, which is gastrinoma. It was one of the neuroendocrine tumors of the pancreas, which produces gastrin, right? And gastrin obviously causes the parietal cells to go into overdrive and produce too much of acid. Okay, this is a nice one. 34-year-old female presents with a 2-year history of flushing, diarrhea, episodic shortness of breath. What's the diagnosis? Which two lab tests would you do? So this obviously the patient exhibits significant facial flushing, and you guys know this is carcinoid, okay? Carcinoid syndrome. And the two tests which you're going to do is serum chromogranin A and 5-hydroxy indoacetic acid. Okay, HIV positive patient comes in with a CD4 count. Let me just move this taskbar of 49. Presents with diarrhea, anorexia, loss of weight, tenesmus. This is a colonoscopy, and this is the accompanying histology. Okay, so what's the diagnosis here? What is the arrow indicating, and how would you treat this patient, guys? Hmm? Do we have any takers in the house here? She has a very low CD4, guys. Intractable diarrhea. What's your considerations here? Okay, so this is the picture of CMV colitis, and here we have an eccentrically placed a cell with an eccentrically placed inclusion body, and this is the kind of cell that we see um, in CMV colitis. Okay, now remember that you got to have a strong index of suspicion for this because the only way to diagnose it is on scope when you can do a biopsy and send off to histopath, right? And the treatment really is ganciclovir 5 milligram per kg BDIV for 2 to 3 weeks, followed by maintenance ganciclovir until the CD4 is above 100. Okay, and of course, in the same profile of patient, you have to cover with Bactrim as well, because Bactrim is going to cover all your protozoal causes of diarrhea in the immunocompromised. And what are the protozoal causes of diarrhea in the immunocompromised? Microsporidium, Entamoeba histolytica, Giardia lamblia, Isospora belli, Cystisospora, right? All those weird and wonderful causes of diarrhea will be covered by Bactrim, which is trimet sulfur. Okay, but unless you think about CMV colitis, you're not going to do a scope. If you don't do a scope, you're not going to do the biopsy and diagnose it. And you can't just give anybody ganciclovir, without diagnosing it, the CMV colitis. Bilateral peritoneomegaly, guys must have a differential for this. So mumps, alcohol abuse, Sjogren's, sarcoidosis, lymphoma, dehydration, diffuse infiltrative lymphocytic syndrome, malnutrition, and it goes on. A patient with a history of gastric ulcer comes in with weight loss, anorexia, vague epigastric pain, early satiety. Now, this is important. A brown velvety rash in the neck and axilla, which in the flexures, you guys know, most likely acanthosis nigricans. And she has a microcytic anemia. Okay, guys, now remember that acanthosis doesn't only indicate insulin resistance. Yes, it is one of the common signs of insulin resistance, but it can be a harbinger for gastric carcinoma as well. So just be aware of that, right? Okay, this is a long one. Previously healthy patient with a family history of so-called colitis comes in with weight loss, fatigue, fever, crampy abdominal pain, bloody mucoid diarrhea, tenesmus, has significant microcytic hyperchromic anemia, probably iron deficient, negative C. diff, negative stool over parasites culture, negative Saccharomyces cerevisiae, so probably unlikely Crohn's, but a positive P anchor. Thank you. Scope shows no disease, upper scope, but lower scope shows inflammation and ulceration that extend proximally from the rectum to beyond the sigmoid without skip areas. Guys, I'm making it very clear here. Bowel pathology shows distorted crypt architecture with crypt abscesses. Can somebody tell me what is this the prototypical exam script for? Hmm? Anybody type in the chat box. Or if you want to unmute yourself, even better. Yes. Let's see what we have in the chat box today. Okay. Please, there's colonoscopy. All right. Yeah, this is colonoscopy. So this is the prototypical picture of ulcerative colitis, guys. Ulcerative colitis. Now, so obviously there's some inflammatory bowel action happening. And the fact that the patient has not skip lesions, but has continuous inflammation. And we remember we said with UC, by definition, it involves the colon, and it has to involve the rectum, and it moves proximally from the rectum. You can have some backwash ileitis, but that's as far as it goes, right? And it doesn't fissulize, it doesn't cause fissures. If anything, it causes toxic megacolon. And there's a link between P. ANCA and ulcerative colitis, and between ulcerative colitis and primary sclerosing cholangitis, PSC. And of course, the negative Saccharomyces cerevisiae antibody means, see, so Saccharomyces cerevisiae or ASCA is more closely linked with Crohn's. So if this is inflammatory bowel disease, which is not Crohn's by default, it is ulcerative colitis, okay? Patient less than 45 years old diagnosed with colon cancer. Now, he has the following in numerous first and second degree relatives. Right, now, remember, guys, whenever we say we're bringing in the family, we're bringing in the ethnicity, there has to be some genetic component to what we're talking about. So the fact that he has this in first and second degree relatives means, hey, watch out, there's something genetic going on. Right, so uterine cancer aged below 50, ovarian cancer, gastric cancer, pancreatic cancer, biliary cancer. Oh man, this guy's in trouble. Mismatch the MMR gene mutation. So you guys know what is this? It is called the Lynch syndrome. Okay, Lynch syndrome, otherwise called hereditary non-polyposis colorectal cancer. Just be aware of that one. This is Dupuytren's contracture, most likely seen in alcoholism, but can be seen in diabetes, familial, and in chronic regional pain syndrome. Remember, guys, this is basically thickening of the fascia. Okay, this is Castle's necklace, and Castle's necklace happens usually in thiamine deficiency, isn't it? I beg your pardon, niacin deficiency. So niacin, as you guys know, is vitamin B3. When we speak about the 4Ds, what? Diarrhea, dermatitis, dementia, and death. Okay, all of that niacin deficiency, guys. Okay, how about this one? Intubated patient on a TPN, total parenteral nutrition, suddenly develops new fever, abdominal distension, and pain, may have jaundice, you have leukocytosis. And if you have to do the differential, if you do the differential, you're going to find raised neutrophils and band forms. You've got raised alk phos, total biliary, and transaminases. So it's a increase in your cholestatic enzymes and your transaminitis. Normal amylase. Kidney ultrasound is normal, there's no free air. Abdominal ultrasound shows no stones or sludge, but you do have a thickened gallbladder wall with pericholecystic fluid. Okay, HIDA scan, you're unable to visualize the gallbladder. Guys, this is a very specific entity which we call acalculous cholecystitis. Watch out for this in the ICU. It often happens in the setting of septic patients who are intubated. Okay, elderly man with a history of ischemic cardiomyopathy prevents with biventricular failure. Now, why are you telling us this? This is not cardiology, guys. This is GI today, isn't it? Well, he receives oxygen and diuretics, and then he develops confusion, hours of rapidly progressive periumbilical abdominal pain, vomiting. Initially, he had a soft abdomen, but now the man is distended with guarding. There's no bloody stools. Okay, so probably this is going to be the result of acute mesenteric ischemia. Acute mesenteric ischemia, right? Always be on the lookout for this in any patient who develops sudden hypotension and now has typical, terrible abdominal pain. And one of the things that guides us is the lactate on the gas. So if your bowel is becoming ischemic and infarcted, then your lactate should shoot up. And often what you see there is a discrepancy in terms of the severity of the abdominal pain. The patient has extremely, extremely severe pain in the abdomen, which doesn't really correspond to your other parameters. You got to think about bowel ischemia, bowel infarction. Non-alcoholic patient comes in with several hours and days of intractable nausea, vomiting, epigastric pain that radiates to the back, improved on leaning forward. The patient may have fever, may have an effusion, may have bruising in the flank or around the umbilicus, which we call the Gray-Turner sign and the Cullen sign, leukocytosis with neutrophilia and band forms, a raised amylase, thank you, may have raised transaminases, may have raised total biliary alk phos, and the abdominal KUB ultrasound shows no free air. All right, guys, somebody make my day and tell me what condition is this that we just described. Anybody? Type in the chat box to me, guys. Look at the raised amylase. Epigastric pain radiates to the back, improves with leaning forward. May have fever, effusions, may have Gray Cullen sign, a Gray Turner sign, Cullen sign, may even Fox's sign. We use the dancing criteria, the Apache score, the Alvarado score. Pancreatitis. Thank you, case. Good. Okay, so this patient they're telling us has already developed ulcerative colitis. It comes in now with fatigue, diffuse skin itching, right upper quadrant pain, raised alk phos, transaminase is high but not that high, normal albumin, positive P-ANCA, negative antimitochondrial, so it's not autoimmune hepatitis, negative IgG4, it's not IgG4 related disease, but cholangiography shows you multiple strictures, dilated intra and extrahepatic ducts. So this is the highest yield statement in this scenario. Cholangiography shows you multifocal strictures, dilated intra and extrahepatic ducts. Now, remember, guys, we said that ulcerative colitis is linked with what condition in the liver? PSC. Yes, PSC. Absolutely. Primary sclerosing cholangitis, which involves both the intra and the extrahepatic ducts, versus primary biliary cholangitis, which is linked with anti-mitochondrial antibody and involves primarily the intrahepatic bile ducts, not the extrahepatic. Okay, this patient has alcoholism. What is this now? Very scaly rash. This is the picture of beriberi, which is thiamine deficiency. Now, remember, guys, that it's a very kind of dry, kind of xerotic, scaly rash. And there's two different flavors of beriberi, wet and dry. So wet beriberi, we have the neurological features together with the cardiac failure, the high output cardiac failure. But dry beriberi doesn't have the cardiac failure, but you have the neurological manifestations, the wernicke's, the Korsakoff psychosis, etc. Right? Principles of management, guys. Before you give dextrose to correct any hypoglycemia, make sure your patient has got thiamine. Okay, and the relevant doses are mentioned here. Previously healthy patient comes in with gradual weight loss, fatigue, fever, cramps, diarrhea, bleeding, tenesmus, aphthous oral ulcers, microcytic hyperchromic anemia, negative C. diff, negative stool ova parasites, negative stool culture, but positive anti-Saccharomyces cerevisiae antibody, negative P-ANCA, upper GI bleed with fecal occult blood testing shows you multiple ulcerations and cobblestoning with transmural thickening. Colo shows you areas of inflammation, while thickening, superficial ulcers, skip lesions, no rectal disease. Bowel pathology shows you crypt abscesses with non-caseating granulomas with skip areas. I'm sure you guys know what we're dealing with here. These are all the features of Crohn's disease. Healthy middle-aged patient who has never had problems digesting food now comes in with diarrhea, flatulence, abdominal bloating, with discomfort for 1 to 2 hours after ingesting most dairy products. Now, look, there's a link here with dairy products. And now already you know what you're thinking. I know what you're thinking. We both know what you're thinking. Is it true? There's no issues with ingesting small quantities of dairy, and the breath hydrogen test is negative. Lactose intolerance. Yes, it causes malabsorption, guys. Otherwise, healthy patient comes in with diarrhea and cramps with increased intake of sugar-free mints. Now, sugar-free mints probably contain xylitol or erythritol, which, as you know, has a laxative effect. So this is what we call sorbitol-induced diarrhea. Okay, this you can see fissuring of the tongue, very beefy tongue, and your angular cheilitis. So you know this is probably riboflavin deficiency. Okay, this is the patient who has terrible bleeding gums, and this typical picture of scurvy. So vitamin C deficiency. This is Bertot spots, which is the form of xerophthalmia, which we have with vitamin A deficiency, probably more common in kids. This is Schistosoma mansoni. As you see, this patient comes from the ascites, splenomegaly, has been swimming in Lake Malawi, and they have Schistosoma mansoni. So you've got the side spike, and you know, guys, that this can cause swimmer's pipe stem fibrosis, which is intrahepatic sinusoidal portal hypertension, can also lead to cirrhosis as well. This is Schistosoma hematobium, which causes hematuria. It's different from Schistosoma mansoni. Okay. Patient less than 40 years of age presents with recurrent papulovesicular rash on the thorax and extremities with voluminous stools, foul-smelling, floaty diarrhea, which is steatorrhea, with probably iron deficiency and anti-tarsal terminase antibodies positive. Okay, what's happening here, guys? This is celiac disease. Celiac disease called gluten-sensitive enteropathy. Patients have a hypersensitivity reaction to gluten-containing foods, barley, rye, oats, wheat. Middle-aged male smoker with history of pancreatic cancer comes in with weight loss, fatty floating stool, jaundice, anemia, raised serum alk-Phos, total bili. So cholestatic enzymes are up. He has positive CA 19-9. Pancreatic cancer, usually it's cancer ahead of pancreas. Okay. Now this is the elderly patient who has multiple diverticula. Okay. And has bloating, watery diarrhea, dyspepsia, weight loss, anemia, which is macrocytic. Increased folate, vitamin K, diminished B12, diminished 25-hydroxy. DEXA scan shows T-score below -2.5. You know this is osteoporosis. Upper GI bleed shows delayed motility. Lactose, breath, hydrogen test is abnormal. Okay, so what's going on here? Bacterial overgrowth. Bacterial overgrowth. And bacterial overgrowth often happens, we don't even know that we're causing it, but because of repetitive IV antibiotics, patients with prolonged stay in the ward actually do have bacterial overgrowth, which is why it's a good idea to use probiotics. This is Giardia lamblia. You can see it by the flagella that it has. This is megaloblastic anemia because you've got a multi-lobe nucleus together with very large red blood cells. Usually, a neutrophil should have 3 to 5 lobes. This one has 1, 2, 3, 4, 5, 6 lobes. Okay, so MCV is going to be high. And the way you think about megaloblastic anemia, we'll talk about it during hematology installment. But essentially, there's macrocytic and non-macrocytic megaloblastic. Uh, megaloblastic and non-megaloblastic macrocytic, sorry. So megaloblastic is B12 folate deficiency and all the causes thereof, whereas non-megaloblastic macrocytic anemia is more liver disease, hypothyroidism, reticulocytosis, myelodysplasia, myelofibrosis, drug-induced, and so forth. This is what we call Pityriasis rotundum, a very, very nice kind of round circumscribed lesion, which we often have an association with, believe it or not, hepatocellular carcinoma. This is a patient with systemic sclerosis, and you can see she has systemic sclerosis with a very, she looks very young for her chronological age, very, bound down skin, very shiny, bound down skin. If you ask her to open the mouth, she'll have microstomia, the salt and pepper pigmentation, which you can see on the torso and on the face. Very tight skin. Okay, and this is what we call gastric antral vascular ectasia, which is also called a watermelon stomach because it looks like that, and they predisposed to GI bleeding. Okay, but other things that can go wrong. So systemic sclerosis is infamous for affecting the bowel. You can have esophageal dysmotility, GERD, Barrett's esophagus, malabsorption, bacterial overgrowth, constipation, pseudo-obstruction, diarrhea, and so forth. Okay, back to our theory questions. What's the time, guys? Okay, we got 20 minutes more. Young female patient comes in with intermittent crampy abdominal pain, worse with stressful situations. Now they're making a very important connection here. Better with defecation, it never wakes up from sleep. Now that it means it cannot be organic disease, it's most likely psychological issues. Alternating loose mucoid stools, constipation with belching or without belching. No anorexia, no weight loss, normal FBC chemistry and serum CMP. You guys know what this is irritable bowel syndrome. You use your Rome 2 criteria, right? Young patient with family history of colon cancer and the screening colo has more than 100 adenomatous colorectal polyps. And this, you guys know, whenever they say family history, it's a genetic syndrome, familial adenomatous polyposis. So there's two familial syndromes you guys have to know. The Lynch syndrome, which is hereditary non-polyposis colorectal cancer. And then there's FAP, which is familial adenomatous polyposis. Middle-aged patient presents with several days of left lower quadrant abdominal pain, fever, vomiting, may have diarrhea, may have left lower quadrant mass, normal or increased white cells, normal transaminases, albumin, total bili, alk-Phos, amylase, urinalysis, and you have few diverticula and colo. You guys know this is diverticulitis, inflammation of the diverticulum. Patient with history of ischemic heart disease, recent STEMI and cabbage, presents now with left lower quadrant pain, hematochezia, negative C. diff. Abdo CT with IV contrast is normal. Colon without prep shows you pale mucosa with particular bleeding. You may have hemorrhagic blue nodules, guys. So you know that this is some type of ischemia, and so it has to be ischemic colitis. All right. Middle-aged smoker with known ischemic heart disease and hyperlipidemia comes in with dull, cramping abdominal pain that develops about 1 hour after eating, worse with fatty meals. Has weight loss due to avoiding meals, abdominal bruit, and may have a normal ultrasound. That's chronic mesenteric ischemia. Okay, guys, this is massive splenomegaly. As you can see, a huge spleen. So the way you think about splenomegaly is massive, moderate, and small. Massive means more than 8 centimeters or crossing the midline. Moderate is between 4 to 8 centimeters, and anything under 4 centimeters is mild. Okay, and so differential here, you got to say CML, myelofibrosis, also hairy cell leukemia. What about tropical malaria syndrome? What about Gaucher's? You guys know the deals, right? This is Vibrio cholera, which gives you a typical kind of rice water stool. It responds well to your fluoroquinolones. This is palmar erythema, and this is because of increased estrogen to testo ratio, which happens in cirrhosis, but it can happen with oral contraceptive pills, etc. So, pregnancy, thyrotoxicosis, rheumatoid arthritis, polycythemia vera, and so forth, right? This is gynecomastia, and you're going to have a good approach to this. So chronic liver disease, the same reason you have palmar erythema, the same reason you have testicular atrophy, the same reason you have axillary alopecia, the same reason you have gynecomastia. Too much estrogen, too little testo, and then you have these manifestations. But remember, other causes can be testicular tumors. What about drugs like DIG, spironolactone, cimetidine, the older estrogen receptor antagonists, all the way up to adrenal and bronchial cancers, right? This is porphyria cutaneous tarda. Don't want to get into that too much. This is what we discussed before, hypokalemic, hypochloremic metabolic alkalosis with a fair degree of acute kidney injury. So this is most likely a gastric outlet obstruction. Woman older than 30 comes in with gradual onset of fatigue, itching skin, jaundice, hepatomegaly, raised ductal enzymes, normal or increased transaminase. But this is the biggest kicker, guys. Positive antibody, control antibodies. We said this is most likely primary biliary cholangitis, okay? IV drug user comes in with fatigue, malaise, anorexia, RUQ pain, bump in the transaminases, normal enzymes otherwise. Hepatitis B surface antigen positive, Hep C antibody IgM, so anti Hep B core IgM positive. You may have a positive core IgG, a negative Hep B surface antibody, a negative Hep A, a negative Hep C. You guys know this is acute hepatitis B. 95% of the time, we don't treat acute hepatitis B because it is spontaneously resolving. But we may want to consider treating it if it's fulminating hepatic failure. Okay, don't worry about this one too much. Patient known with autoimmune hypothyroidism presents with several weeks of fatigue, nausea, malaise, nebulous abdominal pain, intermittent skin itching, arthralgia, bump in the transaminases, increased total protein. So this is important. Hepatitis screen negative, normal serum ferritin, may have a positive ANA anti-smooth muscle. So you guys already know what we're talking about, autoimmune hepatitis, okay? Obese patient, 40 to 60 years old with type 2 diabetes, hyperlipidemia. So this is most likely, whenever they say diabetes in the question with the liver, it's probably fatty liver disease, and the nomenclature has changed now to metabolic associated steatotic liver disease, right? So the NAFLD. Okay, 40-year-old male with a progressive weakness in the lower limbs extending to the upper limbs over the course of one day. No, man, this is, sorry guys, this is the CNS. I don't know why I put that question in here. Okay, we're winding down now. We've got just about 10 minutes left. Chronic alcoholic with known cirrhosis and stable ascites comes in with fever, confusion, non-tender abdomen. He does have ascites with a neutrophil count about 250. You guys know this is spontaneous bacterial peritonitis. Patient under 30 years of age presents with resting tremor, rigidity, ataxia, inappropriate grinning, drooling, dark rings around both eyes. You guys know this is Wilson's. So Wilson's hepatolenticular degeneration. Diabetic patient with cheilitis, glossitis, confusion, mood alterations. Most likely this is pyridoxine obesity deficiency. Watch out for our TB drugs as well. So isoniazid causes the same situation. Patient with lactose intolerance or anorexia comes in with cheilitis, glossitis, anemia, seborrhea. Okay, so this is most likely a riboflavin deficiency. Known anorexic alcoholic has diffuse hyperpigmented rash that resembles sunburn. So this is probably Castle's necklace, and this is niacin deficiency, pellagra. Homeless drug abuser presents with bleeding gums, petechiae, etc. You guys know this is scurvy. So vitamin C deficiency. Malnourished patient with night blindness. That's all you have to say. There's vitamin A deficiency, which we spoke about. Xerophthalmia, hot spots. Health conscious patient who takes multiple megavitamins and supplements presents with alopecia, diffuse myalgia, ataxia, hepatosplenomegaly, most likely chronic vitamin A toxicity, man. This is a toxicity, not deficiency. Toxicity. Okay, this is a patient who's jaundiced, who has bronze pigmentation and has significant cirrhosis in the liver, has hook-like osteophytes on the second and third metacarpophalangeal heads. You guys know this is hemochromatosis, okay? And we deal with this with desferrioxamine. Guys, it's been an absolute pleasure. Thank you so much. I think we finished a little bit earlier today. Do you have any burning questions about gastroenterology and hepatology? I think we covered the lion's share of what usually features. And I've given you guys some tips and some hints and some catchwords, some buzz phrases. Yeah. Are you guys okay? Give me a thumbs up or maybe type in the chat box, guys, if you're okay. Hmm. Well, now. All righty. Okay, guys, God bless. I think that's it for today. And I'll see you soon with another handy recap. Take care, God bless, and see you soon. Audience.